Hi, I'm Henry, one of the radiology registrars working at SA Medical Imaging. This is a talk on hip and pelvis that's been prepared by one of my colleagues, Christopher and Meredith. So the hope for today, or bringing this back to our learning outcomes, it's to explain the utility of various imaging modalities in spinal and MSK imaging. And in particular around the pelvis, to describe some common fractures, to talk about hip dislocations, and also a bit of a touch on Femoroacetabular Impingement syndrome. So quickly on pelvis X-rays, we'll go through the anatomy that we can see and the various lines of the pelvis. And then talk about stable and unstable pelvic fractures and femoral neck fractures. So starting with the anatomy that we can see on a pelvic radiograph. So fifth lumbar vertebra with its spinous process. Heading into the sacrum, we've got sacral arcuate lines. We've got the sacroiliac joint, the ilium of the pelvis, the crest of the ilium, anterior superior iliac spine, anterior inferior iliac spine. We've got the acetabular margin. We've got the femoral head with its fovea, femoral neck. We've got the superior pubic ramus, inferior pubic ramus, ischial tuberosity, body of the pubis here. We've got the symphysis pubis. We've got the greater trochanter, lesser trochanter, and femoral shaft. So this is just sort of reiterating what we've already seen, and more specifically looking at the ASIS, the AIIS, the acetabulum with its roof. We'll talk about the anterior and posterior acetabulum in a second as well. The ischium and the pubic bone with the superior and inferior pubic ramus. So the standard pelvic radiographs, an AP is supine with the legs slightly internally rotated, and a cross-table view of the proximal femur, again with the legs internally rotated, and important to do without gonadal shielding. A few important landmarks or lines around the pelvis. So Shenton's line is a continuous curved line that connects the inferior body of the superior pubic ramus with the neck of the femur, and it's one of the things that we look for when we're trying to assess potential hip fractures. If it's not a smooth and continuous line, a neck of femur fracture is suspected, or developmental dysplasia of the hip in a pediatric population. This is just demonstrating a few more lines. So we have the Shenton's line, as we've already talked about. We've got the posterior acetabulum, the anterior wall of the acetabulum at the front, the iliopectineal line, the ilioischial line, and then an acetabular tear. It's important when we're assessing a pelvis to check to see all of these lines are intact. So again, the iliopectineal line, ilioischial line, the acetabulum, the acetabular teardrop, anterior and posterior acetabular walls, pubic symphysis, and the sacral arcuate lines and sacral alar themselves. So this is just an interpretation technique. So there are three rings to trace. So trace the main pelvic rim and the obturator foramina. If the rings are disrupted, suspect a fracture, and then look for another one, because it's a complete ring which will fracture in only one place. It needs to fracture in more than one place. Then look at the joint spaces, so the sacroiliac joints and the pubic symphysis. Again, if either are disrupted, think of a pelvic ring fracture. Trace the iliopectineal line and the ilioischial line. and the acetabular teardrop. The Iliopectineal line or iliopubic line is a landmark for the anterior column of the acetabulum, which begins at the sciatic notch and travels along the superior pubic ramus to the pubic symphysis. Ilio-ischial line is the landmark for the posterior acetabular column, begins at the sciatic notch and continues inferiorly to the medial border of the ischium. The acetabular teardrop is the anterior and inferior portion of the acetabular fossa, which should not be located medial to the ilio-ischial line, with the displacement suggesting that there might be an occult acetabular fracture. And then sacral arcuate lines, as we've talked about, they should be smooth and they should be symmetrical. Sometimes they're difficult to see if it's slightly angulated. If they're angulated, if the film's slightly angulated, if the lines themselves are disrupted or angulated, be suspicious for a sacral fracture. Shenton's line, again, smooth, make sure it's not disrupted, and trace the cortex of the femoral head neck, graze to unless a trochanter. If there's cortical disruption or disruption of the trabecular pattern, think of a proximal femoral fracture. Pelvic fractures are mostly stable when there's a single break in the ring, and where there are peripheral fractures. If there are fractures that break the anterior and posterior arches, then these are unstable. Pelvic fractures that are stable include a solitary ischial ramus fracture, unilateral fractures of both pubic rami, ilial wing fractures, or an isolated sacral fracture. So this is an isolated fracture of the inferior pubic ramus or ischial ramus. It's the most common pelvic fracture and more often in osteoporotic patients. Ilial wing fracture is due to direct lateral compression and concerningly can perforate bowel and then become an open fracture. Isolated sacral fractures are usually transversely oriented and difficult to detect on X-ray, either on CT. Unstable pelvic fractures include those with AP compression, like an open book or a sprung pelvis fracture, those with lateral compression, like a windswept pelvis, with vertical shear or a combined mechanism, like a complex fracture pattern. So the most common unstable pelvic fracture is a Malgaigne pelvic fracture. It involves one half of the pelvis and is associated with vertical shear forces, has two vertically oriented ipsilateral pelvic fractures, one anterior to the acetabulum, like the superior and inferior pubic rami, and one posterior to the acetabulum. So this is of the sacroiliac, may involve the sacroiliac joint. There is often cephalic displacement of that pelvis. An open book fracture is where there is disruption of the pubic symphysis and the pelvis opens like a book. Can also be accompanied with sacroiliac joint disruption. So we're seeing here disruption of the pubic symphysis and also right sacroiliac joint disruption. So a windswept pelvis is a complex injury, which is a combination of unilateral AP compression with a contralateral lateral compression. It occurs where there's internal rotation of one iliac wing, causes a unilateral sacral compression fracture, while the same force causes external rotation of the opposite hemipelvis, resulting in widening of the sacroiliac joint. Straddle fractures of the pelvis are another unstable injury. It's considered a vertical shear injury, and it is associated with bilateral fracture of all pubic rami, with elevation of the fracture fragments and a not insignificant association with bladder or urethral injuries. With any pelvic fracture, there can be other associated injuries, pelvic bleeding, which may require embolization, bladder rupture, which can be intra or extraperitoneal, with management changing based on whether it's intra or extraperitoneal. Urethral injury in men involving the membranous or prostatic urethra usually, particularly in a straddle fracture, as we've just discussed, and injury to the sacral plexus or sciatic nerves. Acetabular fractures are relatively uncommon fractures associated with high energy trauma, usually axial loading of the femur from things like fall from height or motor vehicle collisions. They can also occur in low energy trauma in patients with abnormal bone, for example, insufficiency fractures. Important to describe the involvement, which columns of the acetabulum are involved. The anterior column reflects a fracture through the iliopubic line. So you can see if we trace that iliopubic line down, we've got disruption here, and can also be associated with dislocation of the femoral head. Posterior column is the more common acetabular fracture and has disruption of the ilio-ischial line, is also associated with posterior hip dislocations. Transverse acetabular fracture traverses the anterior and posterior columns and has breaks in both the iliopubic and ilio-ischial lines on plain radiographs. Can also be associated with central dislocation or dislocation of the femoral head into the pelvis. This is an example of a acetabular fracture involving both columns, a complex fracture involving both columns, where both the ischio pubic and ilio-ischial lines are disturbed, and there's central, or the beginnings of central dislocation of the femur. Avulsion fractures usually occur in young athletic individuals. The ischial tuberosity or the attachment of the hamstrings at the AIIS, where the rectus femoris attaches, the ASIS, where the sartorius attaches, or at the iliac crest, where abdominal muscles attach. So, like I was saying, iliac crest with multiple abdominal muscles attaching, ASIS for sartorius, AIIS for rectus femoris, greater trochanter for gluteus medius and minimus, iliopsoas on the lesser trochanter, hamstrings on the ischial tuberosity, and the adductor group on the pubic symphysis. Proximal femoral fractures can be described as subcapital, transcervical, intertrochanteric, or subtrochanteric. Intracapsular fractures are fractures of the neck of femur, with subcapital being the most common, but also transcervical or basicervical. This leaves the femoral head prone to avascular necrosis. Extracapsular fractures do not involve the neck of femur, with intertrochanteric fractures being the most common. The reason for potential AVN is that there is the blood supply to the femoral head is mainly due to the medial lateral circumflex femoral arteries, with a small supply to the head via the ligamentum teres. So if there's disruption of the femoral neck, there's a risk of AVN. Intertrochanteric and subtrochanteric fractures. Intertrochanteric fractures are extracapsular fractures between the base of the neck of femur and the lesser trochanter, often passing between the greater and lesser trochanter. Subtrochanteric is distal to the trochanters. Hip dislocations represent a small proportion of of all dislocations. They're usually traumatic and often with high-speed motor vehicle accidents. Can also be a complication of hip joint replacement. The majority of hip locations are posterior, with anterior less common and central even more so. Central, as we've described, can be associated with acetabular fractures. Things to look for on pelvic X-rays for posterior hip dislocation is a femoral head that is lateral and superior to the acetabulum, the femur adducted and in internal rotation. Commonly, you can have an associated fracture of the posterior wall of the acetabulum. Anterior hip dislocations are less common, and they're usually due to force abduction with the femur in external rotation, and usually seen in high-speed motor vehicle accidents. Central hip dislocation, as we've talked about, occurs with acetabular fractures. Again, high-energy trauma, usually axial loading on the femur. You can see here that we've got central displacement of the femoral head into the pelvic cavity, more easily seen on CT, and associated acetabular fracture. Femoroacetabular impingement is increasingly recognised as a cause of early onset arthritis in a non-dysplastic hip, particularly in young patients, as the results, with patients usually presenting with painful limited hip motion. It's as the result of certain morphological abnormalities in the femoral head and neck region, or acetabulum, and it results from the abnormal repetitive abutment of the hip and acetabular rim during hip motion, secondary to reduced joint clearance. Risk factors include high impact sport, overuse, previous slipped capital femoral epiphyses or perfes, acetabular retroversion, or post-traumatic deformities. CAM morphology refers to an abnormal morphology of the femoral head and neck junction, associated with a non-spherical femoral head, and is a possible cause of FAI. It usually involves the anterosuperior aspect of the proximal femur at the head-neck junction, and characterized by loss of sphericity of the femoral head, and a flat or convex in cases. Pincer morphology refers to an abnormality of the acetabulum, in particular what's termed overcoverage, where the anterior or anterior superior acetabular rim has increased contact with the femoral neck. Both of these can lead to femoroacetabular impingement. So this is again just going through normal cam and pincer femoroacetabular impingement. So this is the normal femoral head and neck with the acetabulum and acetabular labrum, which allows full range of motion of the femoral head and neck. In a cam morphology, we have a sort of a bump lesion here at the femoral head-neck junction, which can lead to impingement between the acetabulum and the femoral head and neck, as compared to pincer morphology, where there's acetabular overhang, which causes that impingement. So in this frontal radiograph, we can see that at the femoral head-neck junction, there's this bump which could predispose to, or consistent with cam deformity, and can predispose to femoroacetabular impingement. And on MRI, we can see again that cam deformity with secondary changes of osteoarthritis with subchondral cyst formation. We've also got paralabral cysts on the left here as well. So that's us for pelvis. Thank you.